Welcome to REMLens Orthokeratology Lens Design Training and Certification Presentation. In this presentation, we will provide an overview of orthokeratology and the Bausch & Lomb Vision Shaping Treatment VST process, as well as specific aspects of the REMLens design from XL Specialty Contacts. In order to complete this certification, you must review all slides. Certification will now begin. The ultimate goal of the REMLens Overnight Orthokeratology System is to provide the patient with lenses that can be worn overnight, which create the desired refractive change. Therefore, upon awakening, the patient can remove the lenses and enjoy the benefits of clear, uncorrected vision throughout the day. Pre-fitting patient history and examination are necessary to determine whether a patient is a suitable candidate for orthokeratology with REMLens. Consider patient hygiene and mental and physical state, along with occupation and sleep habits. A corneal topographer is highly recommended for fitting REMLens. The topography of the cornea will provide the pertinent information that helps in the initial fitting, diagnostic evaluation, and most importantly, the follow-up. The initial topography evaluation can provide the amount and position of astigmatism, corneal irregularities, elevation maps, and eccentricity across the cornea. Obtaining high-quality maps with the critical information is vital in first fit success and providing the baseline to which each follow-up visit's topography will be compared. Although lenses can simply be designed from keratometry readings and refraction, providing as much information as possible can help for better first fit success. This can include visible iris diameter, corneal eccentricity, and pupil diameter. REMLens may produce a temporary reduction of all or part of a patient's myopia. The amount of reduction will depend on many factors, including the amount of myopia, the elastic characteristics of the eye, and the way that the contact lenses are fitted. Average amounts of reduction have been established by clinical studies, but the reduction for an individual patient may vary significantly from the averages. The REMLens fitting system offers several diameter options to ensure the best possible fit and treatment for the patient. The overall lens diameter can be a factor in the positioning of the lens. You must have a well-centered lens for best treatment results. The diameter of the lens will also affect the sagittal depth, treatment effect of the lens, and the patient comfort. The recommendations for choosing the REMLens diameter is done simply through a visible iris diameter measurement. If the VID is 11.2 and smaller, choose the 10.0 millimeter lens diameter. If the VID is 11.3 to 12.3, use the 10.6 millimeter lens diameter. If the VID is 12.4 and larger, choose the 11.2 millimeter lens diameter. It's important to evaluate the pupil size accurately in both normal and dim illumination before proceeding to fit a patient with REMLens. Depending on the amount of attempted myopic reduction, the expected treatment area in overnight orthokeratology is usually 5.0 millimeters to 6.0 millimeters in size. Therefore, patients with pupils greater than 5 millimeters in normal illumination and/or greater than 6 millimeters in low illumination may not be suitable candidates. Large pupils may result in halos, glare, or peripheral distortion in dim lighting conditions. A small optical zone diameter produces a small treatment zone and a powerful mid-peripheral steepening, increasing the spherical aberration that affects only the contrast sensitivity but without differences in visual acuity when compared to a larger OZ diameter. The REMLens produces a change in corneal shape from forces exerted on the tear film between the back surface of the lens and the cornea. This causes a gradual and steady compression and possibly a redistribution of fluids and epithelial cells under the lens from the center toward the periphery. The REMLens design is based on a 4-zone system, which is best evaluated starting in the center of the lens, known as the treatment zone, and working progressively to the edge of the lens, known as the dynamic edge profile. The treatment zone is the first curve of the REMLens. Calculated to be flatter than the central corneal radius, this zone provides positive pressure resulting in compression of the central corneal epithelium. Unlike the base curve in traditional GP designs, the central treatment zone, also known as the base curve, is used only to flatten the cornea and is not considered a fit factor. The reservoir zone typically has a radius of 0.5 millimeters to 1 millimeter, or is 3 to 5 diopters or more steeper than the back optic zone radius. It forms an annulus-shaped tear reservoir surrounding the central flat zone, inducing negative pressure. The reservoir zone provides an area for the epithelial cells and intracellular fluid to collect. Manipulation of this zone is independent to the other zones and can be utilized for the treatment of the cornea. The stabilization zone is flatter than the reservoir zone and closely aligns the peripheral cornea, providing a bearing zone to help the lens to center. The fitting relationship can be modified by increasing or decreasing the angle or radius of the zone, thus improving the zone's centering characteristics. Manipulation of this zone is independent of the other zones and can be utilized for the treatment of the cornea. The dynamic edge profile zone is flatter than the stabilization zone and is unique to each treatment zone, which is an advantage when compared to other conventional lens designs. This dynamic zone provides adequate edge lift for lens comfort and movement, along with tear and debris exchange. The manipulation of this zone is independent of the other zones. For the initial lens evaluation, let the lens settle for 10 to 15 minutes in a closed eye atmosphere is vital to fitting success. Evaluate the fluorescein pattern. Evaluate from the inside of the lens to the outside. Treatment zone first to the dynamic edge zone last. Corneal topographer is highly recommended for fitting. The initial topography evaluation can provide the amount and position of astigmatism, corneal irregularities, elevation maps, and eccentricity across the cornea. Obtaining high-quality maps with the critical information is vital in first fit success and providing the baseline to which each follow-up visit's topography will be compared. Topographers are important moving forward in the fitting process to evaluate closed eye lens position and overall fit. Let's discuss fitting goals. The fluorescein pattern should show a lens with definite central bearing, exhibiting at least 4 millimeters of treatment area and up to 6 millimeters with a surrounding 1 millimeter area of pooling. In the mid-periphery, there should be another area of bearing of roughly 1 to 2 millimeters, and near the edge, a thin band of fluorescein of approximately 0.5 millimeters, creating a classic bullseye pattern. Lens movement should be equivalent to or slightly less than a regular GP lens, fitted according to the interpalpebral philosophy. The lens with the steepest positioning zone that allows for 1 millimeter of movement, the lens with the flattest treatment zone that allows the lens to center. When positioning, the lens should position centrally or slightly superiorly to minimize both lens movement and lid sensation. The lens should not ride more than 1 millimeter below center or 1 millimeter above center. Take corneal topography measurements and ensure the maps reflect a centered lens position over the central treatment area. The post-wear topographical map will provide the most information about the REMLens in an overnight environment, and the map can be shared with your XL Specialty Contacts consultant if needed for troubleshooting. Post-fitting corneal maps can be classified into 5 major categories: the central bullseye pattern, the inferior position frowny face pattern, the laterally decentered bullseye pattern, the superior position smiley face pattern, and the central island pattern. Let's touch on the 5 topography categories. The central bullseye pattern indicates excellent overnight centration of the lens. This is the ideal topography pattern. The decentered bullseye pattern is indicative of a lens which overnight has decentered nasal or temporal, often due to a lens in which fitting relationship is too flat in the stabilization zone or the overall diameter is too small. The superior position smiley face pattern is indicative of a lens which has decentered superiorly, often due to a lens which is too flat or too small. The compression of epithelium has created the red steep area on the topography. The inferior position frowny face pattern is indicative of a lens which has decentered inferiorly, often due to a lens which is too steep or too heavy. This low riding position lens has created a superior red steeper area on the topography. The central island pattern will show a small 1 to 2 millimeter central zone of untreated tissue, often caused by a lens which is too steep centrally or mid-peripherally. The central area of non-treated tissue is shown with a solid blue ring around it, followed by another red, steeper area. Lenses that are too deep in sagittal depth tend to decenter inferiorly. Often, a change to the stabilization zone, such as flattening, will help in centration and decrease the lens sagittal depth. Just as in standard GP fitting, lenses that are too shallow in overall sagittal depth will tend to decenter. In order to center the lens, an increase or steeper in the stabilization zone is necessary. This will increase the overall sagittal depth of the lens for centering. Here are the characteristics of a tight or too steep lens with troubleshooting options. If the lens centers with little or no blink-induced movement, you should flatten the depth of the stabilization zone 1 step. If the lens positions low with minimal movement with the blink, you should reduce the lens diameter by 0.3 millimeters. If the dynamic edge lift of the lens is too steep, you should flatten the dynamic edge lift by 1 step. If there is insufficient tear film volume, utilize a preservative-free artificial tear. Here are the characteristics of a loose or too flat lens with troubleshooting options. If there is excessive fluorescein pooling in the area of the stabilization zone, you should steepen the depth of the stabilization zone 1 step. If the lens decenters nasal, temporal, superior, or inferior, you should increase the overall lens diameter by 0.3 millimeters. If the lens diameter is too small, you should increase the overall lens diameter by 0.3 millimeters. Here are the characteristics of a laterally decentered lens with troubleshooting options. If there is an excessive flat-fitting relationship in the area of the stabilization zone, you should steepen the depth of the stabilization zone by 1 step. If there is an excessive flat-fitting relationship in the area of the reservoir zone, little fluorescein, you should steepen the depth of the reservoir zone by 1 step. If there is against the rule corneal astigmatism, you should evaluate astigmatism, elevation differences, and make a Tier 1 toric. If there is a significantly displaced corneal apex, you should increase the overall diameter by 0.3 millimeters. Here are the characteristics of a superior position lens with troubleshooting options. If the radius of the stabilization zone is too flat, you should steepen the depth of the stabilization zone by 1 step. If the overall lens diameter is too small, you should increase the overall diameter by 0.3 millimeters. If there is excessive upper lid interaction or the lens is too thin, you should increase the lens center thickness by 0.04 millimeters. Poor visual acuity can derive from several different occurrences. A patient can be undercorrected, overcorrected, or in some cases have residual astigmatism. Perform a spherocylinder overrefraction checking for correction and astigmatism. The next step is to verify lens and optic zone position through topography and make changes accordingly. An increase in the optic zone and/or the lens diameter is available if patient is experiencing flare, glare, or halos. If the patient is experiencing poor visual acuity, flare, glare, or halos without wearing the lens, you should check the topography for central island. Central islands are small areas of incomplete flattening at or near the visual axis. The islands result in decreased acuity and/or ghosting of distance or near images. Troubleshooting options are: flatten the treatment zone radius 0.50 diopter if the over the lens refraction is not plus 0.50 to plus 0.75. Reduce the sagittal depth by flattening the stabilization zone by 1 step. When the patient is experiencing poor retention of the ortho-K effect, when the unaided acuity does not hold for a satisfactory length of time, you will need to verify lens centration through topography and make necessary changes. If the lens is well centered, flatten the treatment zone radius by 0.50 diopters. This will reduce the overall sag of the lens and create more treatment. For patients that are slow responders to Ortho-K treatment, you should 1. Verify that the patient is compliant with your wearing instructions. Proper wearing time and wearing consistency is necessary for the best possible results. 2. Increase the wearing time and reevaluate the patient in 1 to 2 weeks. 3. If the fluorescein pattern shows insufficient apical application, flatten the treatment zone by 1 step. Central corneal staining can be related to mechanical irritation or compromises in corneal physiology. If the posterior surface of the lens has any deposition, mechanical staining can result. Patients should be re-instructed in proper lens care techniques. Observing the patient through the cleaning and storage process in office will verify any lens care issues. If there are no lens care issues, evaluate the treatment zone to cornea relationship for mechanical irritation from excessive apical touch. Increasing the reservoir zone 1 step will increase the lens sag and relieve excess corneal compression. If the patient is experiencing ocular irritation or discomfort upon lens removal, the lens fitting relationship may be too steep, creating a tight-fitting lens. The REMLens offers an independent dynamic edge option to loosen a lens fit, support better comfort, and create tear exchange. Flatten the dynamic edge lift one step to increase tear exchange. Check for overall steep fitting lens and adjust accordingly. If there is lens adhesion, flatten the dynamic edge lift one step to increase tear exchange. Check for overall steep fitting lens and adjust accordingly. For cleaning of the REMLens, a chemical procedure is preferred over digital cleaning or rubbing, as this is due to the complicated and delicate back surface of the lenses. A drop of moisturizing solution could be instilled in the eye after the lenses have been inserted to provide extra initial comfort, preferably preservative-free. It is mandatory to first instill a few drops of moisturizing solution in the eyes before taking them out in the morning, preferably preservative-free. At the first morning follow-up, first ensure the patient has the correct REMLens in the correct eye. Next, check to see that the REMLens is moving. If the REMLens is bound, instill the recommended re-wetting solution and have the patient look up. With a finger on the lower eyelid, press on the sclera 3 times. Then have the patient look down and press with a finger on the superior lid and sclera 3 times. Check that the REMLens is moving. If it is not moving, repeat the same procedure. Next, check unaided visual acuity and over-refract. Consider checking both eyes together by first showing the 2200 line and then moving down one line at a time. This should provide the wow factor of positive vision improvement in only one night of REMLens wear. Next, check the acuity of each eye separately and perform a subjective refraction. It is not recommended to use an autorefractor as the reading will likely not be accurate. Take corneal topography measurements and ensure the maps reflect a centered lens positioned over the central treatment area. The post-wear topographical map will provide the most information about the REMLens in an overnight environment, and the map can be shared with your XL Specialty Contacts consultant if needed for troubleshooting. Check the physiological response, staining, and any signs of adverse events. Scheduling all of the patient's subsequent follow-up visits at one time is recommended. While the first morning follow-up visit was scheduled very early in the day, the time of day for future visits can be scheduled based on your preference and the patient's availability. You should allow at least 30 minutes for each follow-up visit and have the patient bring their lenses with them at every visit. Additional follow-up visits may be scheduled, if needed, based on visual acuity or lens fitting issues. A checkup is immediately required when there is any symptom. Patient compliance is an important factor in the success of REMLens patients. Here are a few important tips. There is no need to remove the REMLens if awoken during the night, but upon awaking in the morning, it is advisable that patients instill a few drops of the recommended re-wetting solution and wait a few minutes before attempting to remove their lenses. Of greatest importance is that the patient should check that the shaping lens is moving prior to lens removal. While removal of REMLens is usually not a problem for the patient, in some cases it may be necessary to employ the use of a DMV lens remover. Be sure to advise your patients to contact your office if they have difficulty removing the lenses. REMLens features an advanced and revolutionary dynamic edge profile providing superior on-eye comfort. In a side-by-side comparison, REMLens rated higher in comfort against comparable designs. Also, in clinical trials, there was an increased comfort level when only dynamic edge changes were made to the lens fit. REMLens is backed by a hassle-free, no-return warranty, which offers 120 days unlimited returns and exchanges, and paperless credits, which saves you both time and money. This can easily be done directly on our website. This completes your REMLens certification. Please register and submit your certification via the QR code shown to receive your certificate of completion and special REMLens offer. You may also visit excelspecialtycontacts.com/remlens-certificate. Thank you for wanting to make a difference.